So thank you. It's great to be back with the GIST community. Norman and I, every time we see each other, we reminisce about the early days. Some of you know that we started together maybe in the year 2001 or so in this journey to global advocacy. And at some point, you'll see I come more from the CML side of the story. And so at some point in 2011, we sort of, CML and GIST divorced. And some of us that are here that are interested in both diseases had to either duplicate ourselves to try to catch up with everyone. But I think we're still all very close to each other. So I'm happy to be back. Sometimes I have been not able to attend this conference, but I was very happy. I think I invited myself this time, actually. So we've been busy at the Max Foundation, and I'm happy to tell you what we're doing. But I have to start with a picture of Max. This was Max. He was diagnosed with CML before all these TKIs. He was 14. We tried to find a donor for a bone marrow transplant. We never found one. So Max passed away in 1991 when he was 17, and he was my stepson. So that's why we started the Max Foundation, to make sure that other families would have a different outcome than what we had many years ago. And we are committed to the Sustainable Development Goals of the United Nations, and we support, if you know about the Sustainable Development Goals, we support goal number 3, which is decreasing premature mortality from cancer. And that's what we think we are really trying to accomplish because of our history with Max and because we've had a very large CML program. Our major program right now is CML, but I'm often asked, does the Max Foundation has any interest in go beyond CML? And yes, the Max Foundation works beyond CML, and in fact, the second largest disease area of work of the Max Foundation is GIST. So we're definitely very interested in collaborating with you. So our strategy for GIST is to decrease premature mortality from GIST in neglected population of the world through humanitarian access to treatment, care, and support. That's what we're trying to do. And I have to say that our story, and this is when I met Norman, took a turn. We started the organization as a very grassroots organization. We opened an email address, a website at the Max Foundation, telling people how to go about trying to find a donor for a transplant for your loved one. And in the year 2001, when Gleevec came to the market, we entered into a partnership with Novartis. Novartis, some of you know that at the time they said that they were willing to make sure that people in low and middle income countries that could not afford this treatment would have access to it. They were willing to give it, yet they needed an organization that would make sure that the drug would get to the proper patients. And so while this, what became the Gleevec International Patient Assistance Program, and some people know it as GIPAP, it was a new model. They were not willing to just give the drug to the government or to some clinic and not know what happens to it. So they really decided to change any donation model so that instead of bulk donations, they wanted to make sure that every patient that was going to get the drug was properly diagnosed. And so our job, our role in GIPAP became from the beginning to make sure that we verified that every patient existed, that was properly diagnosed for an indication for which the drug was approved, that was treated by a physician, that was a real physician that knew how to treat the disease. And after doing all that, let's say with patient number 1, we would have to tell Novartis to please send 3 months of supply to that physician for that patient. New model, and it seems simple, but it's really not simple, and there was no model to work from. We started to really with a pad of paper and a pen, writing down the names of the patients and figuring this out. And that became the GIPAP program. And so in the GIPAP program, every single patient in the program goes through that cycle because, of course, you know that you have to stay on the drug for many, many years. So our job has been to track every one of these patients to make sure every 3 months we hear back from the physician to tell us that the patient's still on the drug, that they still need more treatment, that they are on whatever dose they are, and then we would tell Novartis to send drug to that physician for that patient in this ongoing cycle. There are about 70,000 patients that have gone through this program. There are about 34,000 patients on treatment right now through this cycle. So in the meantime, in the last 15 years, we became really good, just like you guys specialized in your registries. We specialize in building a system that would help us keep track of every single patient. So every patient has sort of a life cycle in the program, and our team members come in every day, and you can see all the patients that, let's say, need to be reapproved for the program, and physicians can log into our system and give us information in real time. So we are able to keep this massive 75 countries, 30,000 patient kind of program, massive thing going. So I don't think I've ever given Norman facts about GIPAP, so I thought this slide is for Norman, okay? So since 2001, Novartis has provided access to Gleevec through GIPAP in the Max Foundation run program to more than 11,000 GIST patients. Currently today, there are 3,300 GIST patients still in GIPAP. 4 of these patients have been in the program since 2002. I think in 2002, yes. Yes. On average, we approve 800 GIST patients every year in GIPAP. 500 have unresectable metastatic GIST, and about 300 have adjuvant GIST, and it has been pretty consistent, let's say, in the past 10 years, the number of patients that come into the program. And 34 countries have one physician that treats GIST. And I really haven't dug deeper into the data, but I'm pretty confident that some of those physicians are not oncologists, they are hematologists. Right? Because GIST patients represent 10% of the GIPAP population. So of the 34,000 patients that we're following, 3,300 have GIST. So in many countries where we have one cancer center that we work with and one physician that's usually a hematologist, sometimes that hematologist is treating with GIST patients. So a little bit of history of GIPAP. And then I did very quickly a little bit of analysis, but I wanted to know how, how many patients, how many years they stay, and so I plotted the number of years in GIPAP by the percentage of patients in the program. So patients that have been approved less than 1 year ago, 97% are still active today, right? Patients that have been in the program for more than 1 year, 83% are still in the program. Patients that have been in the program for 4 years, 42% are in the program. And then I think that once you've been on Gleevec and you've done well for more than 5 years, I think you sort of stay like that. But I have no idea how this looks compared to live draft data. So I just wanted to give you a little bit of real world data from our perspective. So for some time, as we approach the loss of exclusivity of Gleevec, right? So Novartis was going to lose the patent. We're having all those patients in this Novartis program. People have been, for I think 3 or 4 years, asking me what's going to happen to GIPAP when Novartis loses the patent of the drug. And of course, that has been something that we were very interested also to figure out what we were going to do. We have a lot of patients and a lot of need, and we knew that if we take this program away, in all these countries, there is no access to treatment. So we started talking very specifically about this issue 2.5 years ago with Jeff. I have to say, not because he's in the room, but he was instrumental in working with me to figure out what we were going to do. And not only, I have to say, not only the company said they were committed to the patients, they were committed to the program, but Jeff said to me, let's reimagine what is possible. He said, if you had to do it again after 15 years of learning, how would you do it? And first I said, I didn't believe him, and I said, do not say that to me, because do not give me hope that we can actually do something in the best way that we could if you're not going to do it. But he was for real. We embarked in the journey of trying to figure out how do you now run a program with a drug that's off patent in a large company. I think the vision that we had 2.5 years ago is slightly different. We had many turns along the way, many challenges every time we thought this is what we need to do. Somebody would tell us there's a reason why we cannot do it that way. There are a lot of more reasons why you cannot do something than why you can do something. But about a few months ago, I think, we launched, in fact, we announced, I think last month or so, the new collaboration. We have restated our partnership with Novartis in a new collaboration that we call CML Path to Care, and that has to do more with a large number of patients, CML patients in the program than with the diseases, because of course GIS patients are included in this collaboration. With a new model that has, shifts the program to the Max Foundation, where Novartis is donating the drug and funding to the Max Foundation to run this program, and we will be distributing the drug to all these countries and all these patients within the umbrella of what we call the Max Access Solution. So with everything that we had learned, we have now established a sort of a new model to be able to continue to help patients, continue to bring the drug to the patients, and where, from our perspective, and I know Novartis can speak from their own perspective, but from our perspective, it allows us to do so many more things. While this program was a pharmaceutical company program, have a lot of restrictions. And so now that it's a, let's say, a Max Foundation-led program, we are a lot more free to actually do what the patients need and to collaborate better with organizations like GIPAP or others. So I'm very excited. It is a very complicated and difficult thing to do, to move this program out of Novartis into the Max Foundation. It has been growing internally in this company, and the tentacles are very deep inside the belly of this company, so pulling it out has been very complicated. We are doing a transition of a staggered transition of countries. We have now transitioned today maybe 44 countries out of 70 or so. And we are continuing to doing that, and we are already, as the Max Foundation, we have successfully brought Gleevec into some of the countries already today. So that is what has happened with this program. So what's this Max Access Solution model, this sort of vision that we have as the Max Foundation? The patient is always at the center of what we do, so our program and our model starts with a patient that has gone to a doctor, has been diagnosed with a cancer, has been prescribed a medicine that is not available in their country. And so we have a prescription, we have a patient, we have a diagnosis. We have formed, I think one of the key parts of the model is the physicians. we, for the past 15 years, have been lucky to work with all these physicians that were GIPAP physicians. About 300 or 400 hematologists and oncologists in 70 or so countries. So we have gone back, we have visited many of these clinics this year. Our team sort of went around the world and actually went to the sites and make sure we understood a little bit better how things happen on the ground. And we have formed a network of collaborating physicians. I think we have like 280 at the moment today in 60 or so countries that have signed memorandum of understanding to be part of our network. And they are the ones that can come into our system and send us the applications for their patients when they need drug. We have, in parallel to that, signed collaboration agreements with companies like Novartis that have a scope that says you can operate in these countries with this drug for these many patients, basically. We have then formed a partnership with an international distributor. So when a company, when we request drug, a donation of drug from a company, we ask them to deliver it to our distributor. And then we work with our distributor to bring it to the countries. And last but not least, we have a strong system of support. We have team members. There's about 60 or so Max Foundation team members around the world. And as you know, we work with a lot of patient leaders that we have known for many years, some of them here. My friend Ferdinand, my friend Nikhil, and Piga, and Sylvia, and Vicky, and all of you that I know. We count on all of you to help us provide educational support to the patients so that they can stay on treatment. So that's the sort of the new model in which we want to operate. And the most important thing that we want to create here is a validated end-to-end supply chain into these cancer centers that will allow us in the future to bring other medicines to the patients' need. I want to talk a little bit about our collaboration with Pfizer. You know, as I said, we have a lot of friends. We have known so many patients for 15 years, like Piga. And one of our friends was Hisham from Sudan. And he was a GIST patient, and he was a dear friend who really, on his own, has started a patient organization in Sudan and was organizing all sorts of meetings and support for patients in Sudan. And one day we heard that Hisham was not responding to liver and needed Sudan. And so we went with our deepest advocacy strength to Pfizer and said, we brought a picture and we said, this is our friend and you have to help him. And I have to say that Julie and Margalit and everybody at Pfizer were very receptive. They tried to start figuring out how could Pfizer bring Sutent to this person in Sudan. And Sudan, of course, has the problem of the sanctions that the US government has, so you can't really bring things to Sudan. But there were weeks and months and hundreds of teleconferences internally in Pfizer. They wanted to help Hisham. They decided they could do it through, I think, Egypt or something. The drug got to Sudan the day before Hisham passed away. So we were not able to help him. And on my side, I think all of us that worked on this and all the people at Pfizer, I think, were very traumatized by the experience. And all of us said, let's make sure this will never happen again. And so this was 2014, 2015, before the Novartis model. So really for the Max Foundation, we said to Pfizer, by then we had learned quite a bit in the last few years about importation and logistics and import permits and all these regulations. And we said, we can do it. Just let us show you that we can do it. And let's do a little pilot. And we will bring the drug to the patients. And so I will forever be grateful to Pfizer because they believed in us and they gave us a chance. And we learned a lot with the pilot collaboration that we have with Pfizer. And now it's been 2 years. And so we can bring Sutent to patients in many countries today. So, how do we support, how does Max Foundation support GIS patients in low and middle income countries? I told you my talk is the good, the bad, and the ugly. So I told you a lot about the good. We call this a humanitarian pact we make with pharmaceutical companies to help patients. And we have several pharmaceutical companies that have signed up for the pact. Of course, 2 of them that have GIS drugs. Today there are 45 countries in the world where if you need Gleevec or Sutent, you can have access in humanitarian grounds. And I think that is amazing. Since we started, we would have never envisioned that this was possible. So I want to take a second to just take it all in. And if we look at the sort of the map of all where we are operating, with many of you, I sit a lot in meetings, sometimes meetings that talk about clinical trials, and you see my friends in Africa especially, it's always white, there's nothing there. So I'm very proud of this map and where we're working. So that was the good. Just remember the good, because the bad is bad. So there are many barriers beyond access to the drug, to access to treatment in low and middle income countries. And first of all, many governments don't reimburse these drugs. So it's impossible to have access if the government does not reimburse, or if the country does not have universal health care, and the people in the US know that very well. Many times the products are not even in the national list, and that's what many of you have been working so hard to try to get the drugs put in the national list. Or you have private health insurance, but it doesn't cover it. Or if it covers it, you cannot afford a copay, and that's a common problem in the US. You cannot afford to privately purchase, or you can afford for only a few months. I didn't tell you this, but Hisham, when he was just diagnosed, he sold his house to buy his first box of Gleevec before he learned about GIPAP. So that happens. When the product is not registered in the country, there's not even, if you have all the money in the world, you can't buy it. So that doesn't take you anywhere. And many times, and I didn't understand this, but it's registered but not commercialized. So you still can't buy it even if you have money. This is one of the hardest to understand. Some governments do not accept donations of medicines. It is illegal in some countries to donate medicines to the people of that country. Hard to understand. Some governments want to impose taxes on the donation. So we had a big problem last year in India when they started taxing the drug that Novartis was bringing in to donate to the people of India. Hard to understand. Many times the importation process is so difficult that it makes it very hard to stay on the drug on a continuous basis and be adherent because of the regulations that also change all the time. And in order for us to be able to, we have to comply with the European and international regulations of the FDA and the EMA. So sometimes you go to a clinic in a developing country and they want the standards to be the same as it was in Switzerland or somewhere. So it's very difficult to find a clinic where you actually legally can operate. Many times there's no diagnostics, and you know this very, very well with GIST. Or surgery, and I always think with a disease like GIST where you have to have surgery, one of the hardest problems in low-income countries, I think, is the availability of clean blood products. There are no blood products, so you can't have surgery if you can't have a blood transfusion. Substandard government programs to me are really dangerous because it seems like there's access, and yes, the government has a program, but today I come and they give you 3 pills and they tell you to come back to get another 3 pills tomorrow, and nobody can stay for many years in a program like that. Sometimes, like it happened to Pfizer when we tried to help Hisham, the manufacturer does not have a pathway to provide humanitarian access, and that's what I'm trying to make sure that doesn't happen. If somebody wants to help, I want to make sure they can help. Sometimes we have the drug, but the patient cannot afford the diagnostics. And other times, patients cannot afford to pay the consult to the clinic. Or the patient cannot afford their bus. We had a patient not too long ago who had not come back to the clinic in India. And my colleague called him, and he said he was trying to raise the dollar he needed for the bus fare to the hospital. So people just cannot keep coming. Sometimes they come from very far away. They need a place to stay, so it's not only the bus fare. They need a place to stay overnight, and they cannot afford. And many patients are day laborers, so if they don't work, they don't make money, and they can't every 3 months or however many months not work because they have to come to the clinic. There's a lot of stigma. Most patients cannot disclose their diagnosis. So how do you ask for the day off if you cannot tell somebody that you're sick? Right? And this patient, the hospital cannot import the import fees. So we talked about importation and the problem of the so it's tough. It's tough. It's many barriers to access to treatment. And then there's the ugly. And the ugly to me is that we have countries where we cannot treat GIST. There is no cancer center. In fact, in these countries, I don't think you can treat cancer. The patients are there. But we haven't found a institution, a doctor, a clinic that would be able to work with us in all these countries. So remember, there was the good, because it's so depressing. But I do say to myself and to all of us, I think what we have to ask ourselves is how can we contribute to the good, improve the bad, and change the ugly. And I do want to put here a note that was sent to us by a physician in Kyrgyzstan, one of the countries where we help, that she said, you know, providing life-saving treatment to one patient does not only save the life of that patient, it saves the life of the children, the elderly, family members, and everyone in the community who depends for their survival. So I am happy to be here at Life Raft. I think the future has a lot of opportunities for us to work together. I want to say, you know, if we cannot figure out how to better partner now, you know, shame on us. And I want to make sure that next year we can come back and say this is what we are doing together, because, you know, there's a lot of barriers, but also there's a lot of opportunities that help. So thank you so much.
Any questions? Comments? Questions? Comments?
I have a comment, and it is that you have done something really quite extraordinary over the years. You have built an international organization working with our friends in Nevada. It's not so easy sometimes. We started out, Pat and I, walking in Basel, Switzerland, walking into the office of a guy named Dan Vasella, who came out to greet us. I don't think either one of us knew quite what we were doing at the time. And look what's happened. Look what's happened. There are a lot of people who are alive today because of what you've done, Pat. Good job.